Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 342 of our pharmacotherapy series, entitled Care of the Critically Ill Adult. The first case reads, SCM is a 62-year-old male who comes to the ICU with an upper GI bleed. He reports a 2-week history of poor oral intake and weight loss. For the last 2 days he has had several episodes of bloody stools and presented to his local clinic today with the following vitals. Blood PR pressure of 90/51 mm of mercury. A heart rate of 110 beats per minute. A body temperature of 36.2 degrees Celsius. He is brought immediately to the emergency department where the following labs are obtained. A hematocrit of 17%. A WBC of 8.2 times 10 power 9 per liter. An INR of 5.2. Sodium levels of 128 milliequivalents per liter. Potassium levels of 3.1 milliequivalents per liter. A serum creatinine of 1.9 mg per deciliter. His current home medications are aspirin 81 mg daily, clopidogrel 75 mg daily, atorvastatin 40 mg daily, metoprolol XL 50 mg daily, lisinopril 10 mg daily, and warfarin 7.5 mg daily. The patient is immediately transfused with 2 units of red blood cells and is brought to the ICU. Which of his home medications should be held after he is admitted to the ICU? For the non-surgical ICU patient, the indication for admission is a major determinant in what medications can be restarted. Often medical ICU patients come in with hemodynamic instability, reduced left ventricular ejection fraction, and/or alterations in renal or hepatic function, which significantly alter baseline pharmacokinetics. These patients must be evaluated on a case-by-case basis to determine if home medications should be restarted. Patients are admitted to the ICU because they need frequent monitoring and are in constant need of re-evaluation. The medical team must consider that withdrawal can manifest from discontinuation of chronic home medications, e.g., beta blockers, or baclofen, or from discontinuation of other illicit medications, e.g., heroin, cocaine, or methamphetamine. Obtaining thorough patient history helps prevent withdrawal. However, because of the frequent inability to obtain a medical history, the ICU team must determine if withdrawal treatment is appropriate based on vital signs and physical exam. This section will discuss home medications and how they should be addressed in common scenarios encountered in ICU patients. Hemodynamic instability is one of the most common issues encountered in ICUs. Common causes of hypotension include hypovolemia, heart failure, and infection. Knowing the patient's baseline blood pressure can help determine the seriousness of the hypotension. A drop in baseline blood pressure can result in hypoperfusion and in the development of shock. If a patient cannot maintain adequate blood pressure, vasoactive medications, e.g., norepinephrine, epinephrine, phenylephrine, or vasopressin, need to be initiated. Common indicators of lack of perfusion are monitored in the ICU, including cool skin, metabolic acidosis, change in mental status, elevated serum lactate levels, and reduced urine output. If a patient comes to the ICU with hypotension and signs of hypoperfusion, home blood pressure medications of all classes are held until there is a resolution of the underlying cause of the hypotension and hypoperfusion. Blood pressure medications should be slowly added back on at reduced doses to the hospital medication regimen. Severe cases of hypertension in the ICU must be dealt with urgently to prevent stroke and/or end organ damage. Common causes of hypertension in the ICU are missed hemodialysis, medication non-compliance, volume overload, and pain. The differential of high blood pressure is extensive, so determining the cause of the elevated blood pressure will help determine the direction of treatment. Hypertensive emergencies, defined as a large elevation of systolic blood pressure or diastolic blood pressure, that is greater than 180 systolic or greater than 120 diastolic, respectively, need to be treated immediately because of possible complications, including cerebral infarction, intracranial hemorrhage, aortic dissection, and renal failure. Intravenous medications are often required to control blood pressure in the emergency room or during the early hours of ICU admission. Common medications used are nicardipine, diltiazem, hydralazine, esmolol, labetalol, and enalaprolat. These medications work immediately and can be titrated to lower blood pressures to desired targets. Intravenous medications are used in the short term until chronic antihypertensives can be administered and titrated. Restarting home blood pressure medications in the ICU is important unless there is a contraindication, i.e., new renal dysfunction, or the patient now has a new condition that warrants a change in medication class, i.e., beta blockers and ACE inhibitors for new heart failure. Since renal function is often unpredictable and unstable in the ICU, many classes of medications are withheld in the ICU. Renal function can change very quickly in the ICU, and classic indicators of renal function such as serum creatinine, which is used in creatinine clearance equations like Cockcroft and Gault, and the simplified four-variable MDRD equation, are delayed in acute renal failure or falsely low in the elderly. For this reason, drugs that can be monitored using therapeutic drug monitoring, e.g., in the case of vancomycin, should be monitored frequently. Other indicators including urine output, blood pressure, and volume status should be factored into determining an appropriate dosing for medications that are eliminated through the kidney. All medications administered in the hospital setting should be monitored daily and adjusted based on renal function. Diabetes mellitus medications can cause complications in the ICU. Metformin can cause a metabolic acidosis if given to patients with renal dysfunction and is withheld in most ICU patients. Sulfonylureas are also withheld because of the frequent changes in diet in the ICU, which can result in hypoglycemia. As a substitute to prevent hypoglycemia, most patients are converted to a short-acting sliding-scale insulin regimen, which accounts for poor oral intake or the withholding of nutrition at certain points in an ICU stay. Sliding scale insulin regimens give varying doses of insulin based on a patient's most recent glucose level. Basal insulin can be considered for known diabetics, who are not receiving adequate control from sliding scale insulin. For a new ICU patient, knowing a patient's home medication pain regimen can be very helpful and often vital to good patient care. A patient on chronic opioids should be continued on a pain regimen, which includes opioids unless there is a contraindication to do so. Often the regimen must be modified to account for renal function and route of administration. For example, many of the long-acting medications cannot be crushed and put down a feeding tube, and a patient with renal dysfunction may need a lower dose or switch to an opioid that is not cleared through the kidney. The dynamic nature of the ICU can make anticoagulation a very challenging issue in the ICU. Unless the patient will likely be in the ICU for a short period of time, vitamin K antagonists, e.g., warfarin, or the new oral anticoagulants, e.g., dabigatran, rivaroxaban, apixaban, will often be held in the ICU to prevent complications surrounding procedures and the altered pharmacokinetics in ICU patients. A detailed patient history is essential to determine the indication for anticoagulation. This will help the medical team determine if full anticoagulation should be continued. The discussion to continue anticoagulation will be determined on a case-by-case basis after weighing the risks and benefits of anticoagulation and often discussing the issue with consult services such as cardiology, vascular surgery, and the primary care provider. If full anticoagulation is required in the ICU, unfractionated heparin, abbreviated as UFH, may be the best option, because it can be stopped and reversed if needed. Almost all patients in the ICU are at increased risk for a venous thromboembolism, abbreviated as VTE, because of lack of mobility, elderly age, that is equal to or greater than 70 years, heart failure, respiratory failure, previous VTE, acute infection, obesity, and/or ongoing hormonal treatment. Because of increased risk for VTE, patients should be placed on anticoagulant thromboprophylaxis with low molecular weight heparin, abbreviated as LMWH, low-dose unfractionated heparin, abbreviated as LDUH, BD, LDUH-TID, or fondaparinux unless a contraindication exists. One of the biggest complications for a pharmacist in an ICU patient is finding an ideal medication regimen for a patient who cannot take any medications by mouth, or that have a feeding tube. For patients who have a feeding tube, medications can be given down the feeding tube in certain circumstances. The pharmacist must determine which home medications can be crushed or come in a solution or liquid form. Often long-acting medications must be converted to immediate release, or the medication must be changed so it can be crushed to go down a feeding tube. The ISMP has created a resource for medications that cannot be crushed. It is available at http://www.ismp.org/tools/donotcrush.pdf. Certain patients in the ICU will be ordered to not receive anything by mouth, including medications. It should always be clarified with the medical teams whether a nil per ost, abbreviated as NPO, meaning nothing by mouth, order includes medications. Many circumstances allow for the patient to receive oral medications on an NPO order. If medications cannot be given by mouth, or there are concerns about absorption in the GI tract, the ICU teams will request that medications be converted from oral to intravenous form. While some medications have intravenous formulations, many do not. A clinical pharmacist can assist with dosage conversions, frequency of administration, and alternative options for medications that do not have intravenous equivalents. Because of the fact that SCM is actively bleeding, all anticoagulant and antiplatelet medications should be held. SCM should have his aspirin, clopidogrel, and warfarin held. Additionally, because he has an elevated INR, he should receive vitamin K to reverse the effect of warfarin. Once his bleeding has stopped, the team will have to determine which medications can be restarted and at what time the medications can be restarted. The next case reads, DHL is a 68-year-old patient with a past medical history of coronary artery disease, with a drug-eluting stent placed 11 months ago. Diabetes mellitus, and atrial fibrillation, who will be undergoing a knee replacement procedure in 1 week. His home medications on arrival to the hospital today, all of which are taken orally, include aspirin 81 mg once daily, clopidogrel 75 mg daily, metoprolol XL 100 mg once daily, and metformin 1000 mg twice daily after breakfast and dinner. All of his labs are within normal limits on the day of arrival. The surgery team wants your advice on what medications should be continued throughout surgery and what medications should be stopped. Consequences of stopping a chronic medication before, or failing to restart that medication after surgery, can be significant. For example, abrupt discontinuation of a beta blocker during the perioperative period in a patient who has been on chronic beta blocker therapy can increase the risk of death in the intraoperative and postoperative period. The American College of Cardiology, American Heart Association, abbreviated as ACC/AHA, recommends continuation of beta blocker therapy in patients undergoing surgery who are receiving a beta blocker for treatment of conditions with ACC/AHA Class I guideline indications for the drugs, e.g., angina, symptomatic arrhythmia, and post-myocardial infarction. Angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers increase the risk of hypotension after induction of anesthesia when these agents are not withheld 24 hours before surgery. Stopping the angiotensin-converting enzyme inhibitor before surgery, however, can result in adverse postoperative effects, such as rebound hypertension and atrial fibrillation. Therefore, the decision to continue or stop the angiotensin-converting enzyme inhibitor or angiotensin II receptor blocker before surgery is made on an individual basis, taking into consideration the indication for the angiotensin-converting enzyme inhibitor or angiotensin II receptor blocker and the type of surgery. Calcium channel blockers, clonidine, amiodarone, digoxin, and statins should be continued. Preoperative withdrawal of a statin in a patient undergoing major vascular surgery, for example, increases the risk of myocardial infarction and cardiovascular death after surgery. Diuretics are typically held the morning of surgery to minimize the risk of hypovolemia and electrolyte abnormalities. Oral antidiabetic agents and non-insulin injectable agents are typically held the morning of surgery and not restarted until normal food intake resumes. In patients with renal dysfunction and those who may receive IV contrast media, metformin should be discontinued 24 to 48 hours before surgery to reduce the risk of perioperative lactic acidosis. For patients on insulin therapy, a portion of the morning dose of intermediate or long-acting insulin is generally administered on the day of surgery after a check of the patient's blood glucose. Close blood glucose monitoring guides subsequent insulin doses to avoid hypoglycemia. Antiepileptics, antipsychotics, benzodiazepines, lithium, selective serotonin reuptake inhibitors abbreviated as SSRIs, and serotonin and norepinephrine reuptake inhibitors, abbreviated as SNRIs, tricyclic antidepressants, abbreviated as TCAs, and carbidopa, levodopa have a greater risk for withdrawal or disease decompensation than for perioperative complications. These medications should therefore be continued up to and including the morning of surgery. Non-selective non-steroidal anti-inflammatory drugs, abbreviated as NSAIDs, reversibly inhibit platelet aggregation, and are often stopped 1 to 3 days before surgery, depending on the duration of action of the drug. Celecoxib does not affect platelet aggregation and may be continued up to and including the day of surgery. Non-selective non-steroidal anti-inflammatory drugs and celecoxib should be held if there is a concern for impaired renal function during or after surgery. For patients on anticoagulant or antiplatelet therapy, the risks for thromboembolism must be balanced with the risk for bleeding during and after the surgical procedure. For patients on warfarin, who are at high risk for perioperative thromboembolism, bridging anticoagulation therapy with IV heparin or low molecular weight heparin before surgery is recommended. Warfarin may not need to be discontinued if the patient is undergoing minor surgery, e.g., certain ophthalmic, dental, or dermatologic procedures. For patients who have had coronary stents recently placed, discontinuing antiplatelet therapy prematurely can significantly increase the risk of perioperative stent thrombosis and have catastrophic consequences. The 2014 ACC/AHA Guideline on Perioperative Cardiovascular Evaluation and Management of Patients Undergoing Non-Cardiac Surgery Executive Summary recommends that patients undergoing urgent non-cardiac surgery during the first 4 to 6 weeks after receiving a bare metal stent or drug-eluting stent implantation should continue dual antiplatelet therapy, that is aspirin plus P2Y12 platelet receptor inhibitor, unless the relative risk of bleeding outweighs the benefit of the prevention of stent thrombosis. They also recommend that the management of perioperative antiplatelet therapy be determined by a consensus of the surgeon, anesthesiologist, cardiologist, and patient, who should weigh the relative risk of bleeding with those of prevention of stent thrombosis. Traditionally, it was thought that patients who have been taking long-term corticosteroid therapy before surgery will experience adrenal insufficiency in the perioperative period and should receive a supplemental stress dose of hydrocortisone or methylprednisolone during and up to 2 to 3 days after surgery. A recent review of the literature, however, found that patients on long-term corticosteroid therapy only require continuation of the normal daily dose of corticosteroid in the perioperative period. These patients are generally able to increase their endogenous adrenal function above their baseline corticosteroid dose to meet the increased demand from surgery. A supplemental stress dose of corticosteroid is not necessary. These patients can be closely monitored, and if hypotension develops, a stress dose of a corticosteroid should be administered at that time. Patients who have a known dysfunctional hypothalamic pituitary adrenal axis deficiency, e.g., Addison's disease, on the other hand, will require supplemental corticosteroid doses in the perioperative period, as they cannot increase endogenous cortisol production to meet the increased demand from surgery. Opioid-dependent chronic pain patients who undergo surgery often experience more severe acute pain after surgery. These patients should receive either the chronic opioid medication or a comparable dose of an IV opioid the morning of surgery to meet their daily requirements to avoid uncontrolled pain and opioid withdrawal symptoms. The use of non-opioid analgesics or analgesic techniques, e.g., acetaminophen, peripheral nerve blockade, epidural analgesia, for perioperative analgesia should be maximized in a postoperative patient. For DHL, since his stent is over 6 weeks old, his clopidogrel should be held 7 days prior to surgery. His warfarin should also be held 5 to 7 days prior to surgery and likely does not need bridging with unfractionated heparin or low molecular weight heparin. His aspirin can be continued through surgery. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 343.